It's Bindu. I don't see the name here.
Sir, I tried calling her. She's on duty today. An emergency case has been taken. I'm trying her, but couldn't reach it again.
Okay. So then I will just show you the answers for that. Uh, in the class. So the importance of positioning. This question has been asked 2 or 3 times in your theory paper, and also from practical point of view, you have to know what is the importance of various positions that are adopted for surgery and what is their anesthetic implication. So, is the screen visible? The question asked is enumerate various positions in relation to anesthesia and discuss
Visible.
in detail the problems associated. Are you able to see the screen?
Yes, sir.
Okay. So 4 important things you have to remember that the positions can cause to the patient. They can affect their respiratory system because the splinting of diaphragm or preventing the normal exertion of diaphragmatic movement that will cause respiratory complication. The second is it can affect the hemodynamics, like when you give a reverse Trendelenburg with a head up tilt for some surgeries, then the pooling of blood will happen in the lower limb, the venous return will decrease, and patient may have hypotension. Or if you give a steep head down tilt, or as you do for a robotic or for a laparoscopic surgery, too much of blood will come to the heart, and patient who is in already a failure may experience a heavy preload and going for cardiac failure problems, pulmonary overloading. So second is the hemodynamic complication. Third is the nerve and pressure source, nerve injuries and pressure source. And last one is the venous air embolism. So these are the 4 important systems and complications that can happen unless you take proper care to avoid these things by during positioning of the patient. And the various positions that are adopted in anesthesia can be supine, lithotomy, lateral decubitus, prone, and sitting. So these are all the 5 important commonly used positions. Mostly we do it in supine. Mostly obstetric and gynecology or the colorectal surgeons, they prefer lithotomy, and shoulder surgeons prefer a lateral decubitus position. Spine surgeons prefer a prone position, and neurosurgeons prefer a sitting position. So these are the various surgeries or surgeons which require this particular position. And among the supine position, there are modifications which are called lawn chair position, frog leg position, Trendelenburg and reverse Trendelenburg position. And the common supine position, you can classify them into cardiovascular, respiratory, central nervous, and the benefits and risks of this position. It is compared to upright, awake, and anesthetized patients, they feel comfortable in supine position. And here the venous return is increased, stroke volume is normal, cardiac output is normal, so heart rate will be slightly decreased, SPR will be slow, and mostly this will not produce much of a change in the cardiovascular response. Similarly, respiratory system compared to upright, FRC will be slightly decreased. Total lung capacity also will be decreased, and atelectasis of the lower zones can happen, and VQ mismatch also can happen to some extent. And compared to the upright or sitting position, the central nervous system, the central vein nervous system also is not very much affected in this. Series of drainage also can be normal, or if you give too much of a head down tilt, then it may be affecting a series of drainage. And the benefit is this is the common and easiest position that can be adopted, and In this position, the head neck may be flexed or extended, rotation can happen, and the common areas where the injury of the nerve can happen is the ulnar and peroneal nerve injury. These are the things that can happen, and the modifications that are done already I told you, the long chair position and reverse lumbar position. Now, arm position during supine is we always try to minimize the abduction. Earlier, if you see, most of us were trained to keep it at 90-degree right angle to the body, so that the approach to IV line or BP measurement all will be quite comfortable. But the present concept and teaching is to minimize the abduction as much as possible. And for major surgeries, it is better kept adducted and by the side of the patient, so that the shoulder joint or the nerves supplying the upper limb are not affected. Anyway, hyperabduction should be totally avoided, and limb should be kept supine or in the neutral position. And for lawn chair position, reduces stress on the back, hips, and knees, and better tolerated by patients who are awake or under monitored anesthesia care. Venous drainage from lower limb is facilitated by the lawn chair position, where you elevate the lower limbs. Tension in abdominal muscles reduce, helping wound closure. That is, if you are doing a secondary suturing of a burst wound, flexing the leg at the hip and knee will definitely release the tension on the abdomen and help in the suture. And the frog leg position supports the flex knee is important to prevent the dislocation of the hip joint. And these are the possible nerve injuries that can happen in supine position. Excess abduction can cause traction on the brachial plexus branches. And this is the olecranon, where the ulnar nerve compression can happen, and too much of head rotation may stretch the brachial plexus. So better to keep the head in the neutral position, arm abduction to be minimized less than 90 degrees, and proper padding at the olecranon. These are the three important nerves that you have to take care in supine position. And the pressure points which may cause the skin damage is occiput, then scapular region, then thoracic vertebrae, sacrum and coccyx, and olecranon again, which is a bony point, and calf muscles and the calcaneum. These are the pressure points. So these are the nerve injury sites, three locations: brachial plexus, axilla, and ulnar at the olecranon. But pressure points, you can see, this is very important when you do a long surgery. For example, when you do a major surgery for 10 to 12 hours, these are all the pressure points which have to be taken care of, which can result in pressure necrosis of the skin. Now, this is the supine position with the modifications. You can see here the abduction is very much reduced, and the leg positions are all little flexed. This is mainly for the information for you. You need not write all these things in your examination. And this is the difference between Trendelenburg and reverse Trendelenburg. So in both the positions, it is important that you prevent the patient from sliding off the table. So even though patient is supine, when you do the reverse Trendelenburg or the Trendelenburg, patient can slide off the table. So you can see a strap being tied over the thigh, and some shoulder support will be here. In cases where you want to give a deep Trendelenburg, like you do during robotic surgeries, you have to give a shoulder support so that the patient doesn't slide off the table. And the patient in lateral position compared to supine, there is a reduction in venous return, stroke volume consequently reduces, cardiac output will reduce. To compensate that, heart rate will increase, and the SVR will increase, and pulmonary vascular resistance also will increase. Systolic blood pressure will decrease, and MAP will decrease. So this is the change that you can expect in the cardiovascular system when the patient goes into lateral position. And with regard to respiratory system, FRC will be reduced, total lung capacity will be reduced, VQ mismatch will be increased because the dependent lung will become atelectatic or likely to become atelectatic. So the VQ mismatch also will be reduced. The central nervous system compared to supine, the jugular venous flow increases, jugular venous return decreases, and with neck flexion, you will find all these things getting altered. So ICP raise is also possible. And this is the question that is adopted for major temporal lobe procedures by neurosurgeon or for shoulder surgeries by orthopedic surgeons. And the risks are brachial plexus injury, ear and eye injury, suprascapular nerve injury. All these things can happen in the lateral position. So when you put a patient in lateral, two important things that you have to take care. In the top one, you can see that the head is at a lower level compared to the trunk. So there is a flexion of the cervical spine is at a lower level compared to the thoracic spine. So when you place the patient in lateral like this, you have to take care that you give proper support to the head and make this spine come into alignment. Both the cervical and thoracic spine should come into alignment. Give a roll here under the shoulder of the scapula to prevent the pressure, and give a pillow between the two legs. And you can see the lower leg is flexed and the upper leg is straight. So that is the correct positioning. This is the wrong position where both the legs are kept straight. There is no pillow between this, and the head is hanging. So that is not the correct position to be done. So whenever you put a patient in lateral, go stand at the backside of the patient and see whether this alignment is normal or not. Otherwise, patient may have severe post-op neck pain, as well as neurosurgical patients may have raised intracranial pressure because of this abnormal positioning also. And another method of doing it, the same thing, how to prevent the patient from sliding. You have a support going from shoulder to the table and also on the lumbar and the cuff level. And you can see the spine has been aligned into a straight line, type proper padding, and the axillary roll is given to prevent any injury to the axillary nerves. And the supporting free arm, when you put the patient on lateral, the upper arm which is free has to be supported like this or like this, and it should never be hyperabducted over the head. This is the wrong position that we have to keep avoid, and always give a roll underneath also to support the brachial plexus on the lower dependent side. Now coming to the prone position, which is adopted for mainly spine procedures. Here you can see the venous return is likely to decrease, stroke volume is likely to decrease, heart rate will increase, and SVR and PVR may increase in this case. And once you anesthetize the patient, all these things may likely to go down, and there is likely to be a hypotension in this patient. And with regard to the respiratory system, you may have a leaky mismatch. The abdomen should be kept free, otherwise the lower lung fields will likely to get atelectatic. So always make sure that the diaphragm is able to move freely without any compression on the upper abdomen. And this is the normal position that we all try to do that. And the modification of this, where the head is slightly projecting from the table and the patient is fixed in the position with the leg up with the head support. Can you tell me what this position is called? Anybody? This is called the Conrad position. Okay? So this is done mainly for the cervical approach to either the posterior tumor or the cervical spine approach. This is the modified prone position, which is called the chondrite position. And the sitting position is usually adapted for, again, posterior cervical fixation or for tumors in the posterior fossa. So this is the classical neuro-sitting position which is done, and you can see the stockings and support is given to the leg to prevent hypotension and pooling of blood. So venous thrombosis also is avoided. That stockings is very important for this position. And there is a question on whether the lithotomy position, can it be associated with compartment syndrome, peripheral neuropathy, deep vein thrombosis, and injury? Is it true or false? Are you all there?
Yes, sir.
Yes, sir.
Can it cause compartment syndrome? Lithotomy position?
Yes, sir.
Yes. Peripheral neuropathy,
Yes, sir.
deep vein thrombosis?
No idea, sir.
Yes.
Yes. Hand injury? Hand injury also
Yes, sir.
has been reported.
Yes, sir.
When they bend the lower part of the table, and the patient's hand is stretching towards the thigh, there have been incidences where fingers have been caught in the gap between the table and which is going bent. Okay? So all of them are true. So this is one. Now coming to the sitting and wheelchair position problem, the access to airway may be limited during surgical draping and surgical field. So before we position the patient, we must make sure that the tube is in proper position and properly fixed so that it doesn't migrate inside or outside. And patient is likely to have a lot of secretions. So proper anti-sialagogue treatment should be given before you position the patient in the sitting posture. And during positioning from supine to sitting, gradually patient should be made to sit up. Otherwise, severe hypotension may result in the sitting position. And if non-invasive blood pressure monitoring is used, cuff must be placed on the non-operative arm and not on the leg. So you should make sure that it is properly placed in the hand. And if invasive blood pressure monitoring is used, you should place the transducer at the level of the tragus of the patient. So the transducer which you fix to the saline stand, that should be positioned to the height of the tragus of the patient. And apply padding to all pressure points, particularly the heels, ankles, and elbow. Avoid excessive flexion of the neck. And Trendelenburg position, where you give a head down tilt. The problems are prolonged head Trendelenburg can cause facial and laryngeal edema, and this should be assessed prior to extubation with a cuff leak test in case deep proning or whether there is a evidence of facial edema. Minimizing the amount of intravenous fluid administered in case may help to lessen the incidence of this complication. The endotracheal tube tip may move caudate during positioning, leading to endobronchial intubation in Trendelenburg position. So always auscultate and make sure that the air entry is equal on both sides after putting the patient in deep Trendelenburg position. Now another multiple choice question, venous air embolism is a potential complication of surgery in the sitting position. And regarding this particular complication, all venous air embolism can be detected clinically by decreasing end-tidal carbon dioxide. Is it true or false? One of the important methods of detecting venous air embolism is sudden drop in end-tidal CO2.
True.
Because there is no blood flow. Is it possible to detect all the venous air embolism by this method? The second point is a decrease in oxygen saturation will not always be seen even with large emboli. Is it true or false? Venous air embolism can lead to arrhythmias right ventricular failure and cardiac arrest. Is it true or not?
True, sir. True.
Surgeon has no role in the management of venous air embolism. True or not? One second.
True, sir.
Okay. Hello.
Yes, sir.
Giri, நான் கூப்பிட்டுமா கிளாஸ் முடிச்சிட்டேன். Oh, very good. Okay, thank you, thank you. So the first question is false, because you cannot detect small VAE of less than 10 mm may be detected on transesophageal echo, but not on ETC also. Okay, so only large quantities will completely obstruct the flow from the right ventricle and cause a sudden drop in ETCO2, whereas small VAE will not be detected. With regard to the second one, a decreased oxygen saturation will not always be seen even with large emboli. That the patient receiving high inspired oxygen concentration, then there is a decrease in oxygen saturation may not be very evident. With regard to arrhythmias, it can happen. Definitely, arrhythmias, right ventricular failure, and cardiac arrest can happen with large venous air embolism. And the surgeon definitely has a role, because he has to flush the wound with the saline and to prevent further air absorption. Okay, so it is the surgeon's duty to cover the exposed vein through which the air will be absorbed, and he has a definite role in that. So saying that he has no role is the wrong answer. And regarding complications of patient positioning during anesthesia, eye injury only occurs when patients are position prone, and supine is the only position not associated with injury from pressure areas. And cerebral ischemia can occur in sitting position. Steep Frenulum position may be associated with development of airway edema. So true or false again? Can eye injury only occurs when patients are position prone? Is it true?
No, sir. No,
No,
sir.
it can happen even in
No, sir.
supine if you are not taking proper care of the eye.
Yes,
And
sir.
supine is the only position not associated with injury from pressure areas. Is it true?
False, sir. False.
False. We already showed where all it can have
Yes,
pressure
sir.
points. Cerebral ischemia can occur in sitting position. True or
True,
false?
sir.
True.
Yes, sir.
Very good. Steep Frenulum burp may be associated with airway edema. Yes,
Yes, sir. True, sir.
True.
Right. So all of them are correct. And now problems with Trendelenburg position, reduction FRC, and can cause cephalad movement of the diaphragm. And Trendelenburg position also causes atelectasis, decreased respiratory compliance, and need high airway pressure to achieve adequate air volume. Barotrauma may also occur because of high peak inspiratory pressure. With steep Trendelenburg position, patient may slide down the table and care must be taken to secure the patient. Arms must be secured to prevent falling from arm boards, which can lead to brachial plexus injury. And Trendelenburg position will lead to increase in intracranial and intraocular pressure and should be avoided in patients who cannot tolerate this. Coming to reverse Trendelenburg benefits and risks, FRC is increased in the reverse Trendelenburg position relative to the supine. Lung compliance is increased because the diaphragm can descend very well down because of the head-up position, especially in obese patients. Always remember that you always give a 45 to 60-degree head-up tilt when you induce as well as extubate the patient. They find it more comfortable to breathe if you give a head-up tilt. And hypotension may result from positioning in reverse Trendelenburg position. That is, when you give a head-up tilt, patient initially will have hypotension unless you give proper support to the calf muscle and rush fluids and try to maintain the blood pressure at the level. Hydrostatic gradient between the blood pressure cuff and the brain to be taken care to prevent cerebral hypoperfusion. And these are all the benefits and drawbacks of reverse Trendelenburg position. So increase in intraoperative best intraoperative position, it can ameliorate the deleterious effect of supine position. 30-degree head-up position increases pulmonary compliance, FRC, and maintain the alveolar arterial oxygen gradient, and may be a better solution for than giving a large tidal volume and PEEP. The little bit of head-up tilt will not require a large tidal volume and PEEP to maintain the oxygenation. These are all some of the pictures of Frederick Trendelenburg who did that, and this is the original Trendelenburg position, how they did it. Somebody holding the leg and putting the patient in the head-up position. And later on, the table was modified like this to put the Trendelenburg position. And this is the steep Trendelenburg position nowadays adopted for laparoscopic and robotic surgeries, many of them. And this is the reverse Trendelenburg, especially for obese patients, is very important. And this is called the Fowler's position. Post-operatively, Fowler position and slight head-up post-op positions are comfortable for the patient. And this is the Lloyd-Davis position for the Trendelenburg. And these are all the modifications, how the leg is to be positioned in lithotomy with leg separation. So 90-degree lithotomy is ideal for anal surgery. So you can see the hip is flexed at 90 degree and leg is flexed at 90 degree. So this is called the 90-degree lithotomy. Whereas in gynecology, you can see this is the 60-degree lithotomy. So mostly they don't require that much of straight elevation. So 60-degree lithotomy is ideal for gynec surgeries. And the problems of lithotomy position is used for gynecological and urological as well as lower anal surgeries, and often combined with a slight Trendelenburg position also, that is head down position, which may exacerbate the respiratory implications. And any change in position care must be ensured that no dislodgement or movement of the endotracheal tube in any positional changes. So in lithotomy, you have to be very careful with the endotracheal tube position. And while placing the legs in the lithotomy, which decreases the blood volume in the legs and redistributes this blood volume to the central vasculature, increases venous return and heart, therefore cardiac output. So in susceptible patients, this may increase the central blood volume and can lead to pulmonary edema. So patients who have reduced ejection fraction, you have to gradually increase the leg and put them in this position, and preferably make sure that some fluid overload is avoided in the lungs. And complications can produce peripheral nerve injuries or neuropathies, compartment syndrome, development of venous thrombosis, and while holding the table, you have to make sure the patient's fingers or hands are nowhere near that foldable area. And these are some of the positions that are done for shoulder surgeries. You can see this is the lateral position with the operative shoulder on the upside. This is slightly modified sitting or beach chair position. And this is another lateral position. This is with the kidney bridge being raised for nephrectomy surgery. This is called the frog leg position, where you flex this mainly for the perineal surgeries. And this is where you have to be careful to prevent any dislocation of the hip happening. Okay? This is called the frog leg position. And when you do the prone position, the care of the tube is very, very important. So instead of sticking it with the tape, which can get loosened with the oral secretion, it is always preferable to tie it with a rope or the string. And you have special adapters through which you can put the tape and then tie it through the nape of the neck so that it doesn't move. And you can fix it at a particular level. point, ideal location. And this is called the tube fixation device. And head support in a jelly bag. So you put it only on the forehead. Make sure that the eye is not compressed and there is no pressure on the eye. And these are the positions for the upper cervical and posterior positions. And this is the Mayfield fixator which is done. Make sure that the tube and the circuit are all properly fixed and you have an approach for that. So prone position with head traction for cervical spine surgery, posterior approach. And this is again the sitting position for posterior cranial fossa surgery. You can see the head has been shaved here and the incision will be made on this line. And two major concerns when you do this are hypotension and serious instability during positioning and venous air embolism during the surgery when there's a vein is cut open and large amount of air is sucked into the patient. Okay? So these are the various positions and their problems that you have to remember. Right.